Hello friends, now I will be talking to you about pericardial diseases which include acute pericarditis, constrictive pericarditis and cardiac tamponade. So first of all we talk about acute pericarditis. Causes. It could be infectious or non-infectious. In the infectious, we have the viruses. In fact, viruses are the most common infectious cause of acute pericarditis. Viruses like Epstein-Barr virus, HIV, etc. are the causes. Then bacteria. Tuberculosis. TB is a very important cause. Fungal infection. Then we talk about drugs like hydralazine, procainamide, they are the notorious drug to call pericarditis. Then rheumatic fever. Connective tissue disorders which include SLE. In fact, among the all connective tissue disorder, SLE is the most common cause of pericarditis. It can occur in rheumatoid arthritis. It can occur in ankylosing spondylitis. Then various miscellaneous causes which include uremia, that is chronic renal failure. In uremia it is painless pericarditis. It can also occur in hypothyroid. It can also occur after some trauma or surgery. So there are various causes. Now let's see how patients usually come to us. The usual clinical feature is pain chest. Pain chest. What is the feature? It is retrosternal. Retrosternal. And the classical history is the patient says pain increases on inspiration, especially on lying flat. It increases on lying flat. It reduces on forward bending. This is the typical history of pain chest in a case of acute pericarditis. Then of course patient may have feature of other disease whichever is the cause of causing pericarditis. On examination you get pericardial rub. How to differentiate this rub from the pleural rub? In the pleural rub, you ask the patient to stop breathing. The rub will disappear. But here in pericardial rub will keep on coming even on stopping the breathing or respiration because it is related to heartbeat and pleural rub is related to lungs. So this is the classical feature, rub is there. Now on investigation. You can do ECG. In ECG, what you get is like you get ST segment elevation, but it is the slope is upward. It is saddle shape. Saddle shape rise of ST segment with the concavity upward. With concavity upward, this is in sharp to in coronary artery disease, where you get with ST segment but with convexity upward. So first is ST segment elevation. It's a, and second point is that there is depression of PR segment. PR segment is depressed. So there are two things that you got to remember. PR segment is depressed is the very specific. This is something special. PR segment depressed, and there is ST segment elevation, but it is concavity upward. The treatment is NSAID, and we can also use colchicine. Colchicine prevents the recurrence, and NSAID we use, especially a drug like having anti-inflammatory action also, so it prevents the pain. This is all about acute pericarditis. Now we talk about constrictive pericarditis. Constrictive pericarditis. Causes. Any condition which can lead to acute pericarditis can lead to constrictive pericarditis. So I gave you a list of acute pericarditis just now, the same all, but only notable exception. The exception is rheumatic fever. So pericarditis occurring in rheumatic fever, it does not lead to CP, but point to be noted, in pericarditis due to rheumatic fever, there can be calcification of the pericardium, but CP is not a feature. Now, what are the clinical features of a case of CP? And this we will never understand unless we know the basic pathophysiology, or I should say normal physiology of cardiac cycle. So first we study the normal cardiac cycle. Normal cardiac cycle, physiology of the cardiac cycle. So here is the heart. Here is the mitral valve, tricuspid valve. Now, when the diastole start, the ventricle will expand and this valve will open and the blood will enter from mitral and tricuspid valves. Now, as these mitral and tricuspid valve open normally, there is a rapid flow of the blood into the ventricle, and this is known as early filling phase, but around 70% of the blood come from atria to ventricle during the early diastole. So this is known as rapid filling phase of the myocardium of the ventricle, and around 70% blood comes in the ventricles from corresponding atria. Rapid filling phase, or so called early diastole. So once this is going on, as this tricuspid valve opened, so in the JVP you get Y descent. So Y descent is produced due to opening of tricuspid valve, and blood is coming rapidly into left ventricle also. In a normal heart, normal adult heart, there is no sound in the left ventricle. But if a sound is produced due to whatever pathophysiology, then the sound produced is third sound, S3. That's why S3 is also known as filling sound. Why filling sound? Because this sound is produced in the rapid filling phase of the myocardium. And now I don't need to tell you that Y descent corresponds to third heart sound, because both are produced in the same rapid filling phase of the myocardium. Near the end of diastole, this atria will contract and they will push another 30% of the blood into the ventricle, and that is known as atrial kick. Remember, it is being produced in the late diastole. And just to remind you, this rapid filling phase was in the early diastole, and that pushes 30% of the blood into the ventricles. So when this atria is contracting, so there will be in the right side a wave is produced due to atrial contraction, and in the left side when the blood comes to the ventricle, normally there is no sound, but if due to any reason if sound has to come, that is fourth heart sound, S4. That's why S4 is also known as atrial sound. Why atrial sound? Because this is being produced due to atrial contraction. So now it is very obvious that A wave corresponds to S4, because both are being produced in the late diastole or due to atrial contraction. And now I don't need to tell you that both A wave and S4 both will be absent in atrial fibrillation. So when the patient has developed atrial fibrillation, neither S4 will be there, neither A wave will be there. This is the basic about the cardiac cycle. Now what happened in constrictive pericarditis, the clinical feature? Of course, patient usually symptom is dyspnea is a feature, and the feature has, patient has all the feature of right heart failure, all the feature of right heart failure, that is raised JVP, edema, ascites, all the feature of right heart failure, which the detail of feature you can see in my lecture, video lecture of the heart failure, right? But one thing is there. Remember, in right heart failure, edema and ascites both occur. Usually edema is much more and much earlier than the ascites, but in this, ascites is out of proportion to edema, and splenomegaly is a feature. What else is there? Now, before I go, now little bit of pathology. This is the, now in this CP, pericardium is thickened like a plaster. This is the normal pericardium, but here the pericardium is thickened like a plaster. You can see it's like a plaster, thickened, like a fibrous, thick, calcified. So normally when the diastole occur, pericardial also dilates with the myocardium, but here the pericardium is not expandable, it's fixed, fibrous, calcified. Myocardium has very limited space to dilate. That's why the early diastole is very prominent in this patient. So as the early diastole is very prominent, what you get? You get prominent wide descent. Prominent wide descent. Even the X descent is also very prominent. We get prominent third sound in the left ventricle, and that is known as pericardial knock. Pericardial knock is there. Okay. So clinically, patient has splenomegaly, ascites, edema. So clinically, it looks like cirrhosis of liver. Clinically. And remember, in these patients, there are two important things which are seen. Nephrotic syndrome can occur, and protein losing enteropathy can occur in this patient. The patient is losing protein from kidney also, from protein losing enteropathy from the GIT also. It further contributes to hypoproteinemia in the body, that further contribute to ascites, edema, and as spleen is enlarged, that also become a differential diagnosis of cirrhosis of liver. Now, how to investigate this case? Investigation. If you do ECG, you get low voltage ECG. Low voltage ECG. Chest X-ray, you can see normal size. This is important because in cardiac tamponade it is just like a water bottle appearance, but there can be calcification can be there. Calcification can be seen in the pericardium. Echo is the best initial investigation. It can confirm regarding constrictive pericarditis. In cardiac catheterization, we get square root sign. Square root sign, so called dip and plateau sign. This you can, I think now you can understand better why. Again we go back to basics. As this valve open, suddenly the pressure falls. Okay. As the rapidly blood goes, LA pressure goes down, and suddenly, or you can say rapid flow of blood occurs into left ventricle, and after that there is sudden halt is there. That's why we call it a square root sign or dip and plateau sign, right? And there is one more thing that we see is equalization. Equalization of pressures in diastole in all the four chambers, and this is also seen in cardiac tamponade, and it is not seen in cardiac tamponade, but this is seen in restrictive cardiomyopathy, right? As far as treatment is concerned, you can remove the pericardium is the answer. You can do surgical removal of the pericardium is the only definite treatment. But in the initial stages we can give some diuretics can be given, but otherwise the definite treatment is removal of pericardium. Now the next topic is cardiac tamponade. So before I discuss the symptoms, signs, let's learn the basic pathology. This is the myocardium, this is the pericardium, and the whole pericardium is full of water, liquid, tamponade. So this is the heart. Remember, in CP it was the myocardium, pericardium, and there was a gap. For initial gap was there for myocardium to expand, but in this there is no place. All is full of liquid. So once diastole start, virtually myocardium has no place to expand. It will simply push the water here and there so that it can expand little bit. That's why rapid filling phase is never prominent in cardiac tamponade. Remember, rapid filling phase was very prominent in constrictive pericarditis. As rapid filling phase is never prominent, so we never get prominent Y descent and we never get third sound in cardiac tamponade. As the heart is not able to dilate, expand properly, so there is venous return is reduced, and as the venous return is improved, so return ka, so that JVP is raised. JVP is raised. As venous return is reduced, so thereby cardiac output is reduced, and if you auscultate the pericardium, you hear the sound, heart sound coming from very distant. Why? Because the whole heart is surrounded by water. The sound is coming from, appear to be coming from a great distance. So it looks like to be a very quiet heart. Quiet heart, or at times in massive effusion you may not even hear the sound, or they hear very faint sound. These three are known as together is known as Bake's triad. Bake's triad. What else we get? We get pulsus paradoxus. Pulsus paradoxus. In the pulsus paradoxus, during the normally when the patient is having normal breathing, so there is systolic fall of BP more than 10 millimeter of mercury. This is so called pulsus paradoxus. It's a very important feature, or rather you can say in the periphery the pulse may even disappear at the end of inspiration. But one thing, it's not, this sign is seen in many other conditions. So pulsus paradoxus is also seen in asthma, COPD, pulmonary embolism, and severe hypovolemia. Severe hypovolemia also. These are the other conditions where pulsus paradoxus can be there. We also get Ewart sign. Ewart sign in cardiac tamponade. What is this Ewart sign? As the heart get enlarged, remember in this case heart is enlarged. If you see X-ray, it look like water bottle appearance. It's a globular heart. As the heart is enlarged, it will compress the left bronchus. It slightly compress the left bronchus. So there is some narrowing of the left bronchus, and if you auscultate at the left angle of scapula like this, the way I am showing to you, you may get a bronchial breathing. This is known as Ewart sign. Ewart sign is seen in tamponade. Now patient come with complaint of again breathlessness, swelling in the feet. You do ECG, investigation. Investigation is you get low voltage ECG, but you also get electrical alternance. Electrical alternance. What is this? You see, you are finding variation in the height of R wave. This is why, because heart is beating and it is simply floating in the liquid. That's why you get varying height of R wave in the ECG. Of course, this interval is normal. Same thing happen in AF, but in AF these interval are also changed. So rhythm is normal, but varying height of R wave. In atrial fibrillation, rhythm is also not normal and varying height of R wave occurs. This is electrical alternance. In chest X-ray, you get enlarged heart, so-called money bag appearance. It's a globular heart. Echo is the single best test to diagnose the diagnostic investigation. What you get is echo-free area. Echo-free area. And in the cardiac catheterization, as I told you, you get equalization of the diastolic pressure in all the four chamber, and the pressure is raised also, but you do not get square root sign what we get in case of constrictive pericarditis. As far as treatment is concerned, the treatment is you treat the basic cause. Tuberculosis is one of the very common and very important cause of cardiac tamponade. Treat the basic cause, and otherwise you can remove the fluid by tapping it out. And if the cause is tuberculosis, then not only you give ATT, you also give steroid so that it prevents adhesion of two layers of the pericardium also. So this is all about the pericardial diseases. Thank you very much.